Hey everyone, welcome back to the channel. Today we are here with Alison Gibson. Alison has a pretty vast health information career, over 15 years, executive leadership, value-based care, and she's very passionate about advancing healthcare systems that align with incentives, improve efficiency, and optimize care delivery. So thank you so much, Alison, for coming down to the studio today to record this podcast. So first, I want to know a little bit about your journey in health information, because you are more overall health information based than you are just like medical billing and coding based. So can you walk us through like your health information management journey and how you got to where you are today?
Sure. 15 years or so I feel like it kind of ends up being a bit of a long story. But I actually started by getting a temporary placement when I was 20 years old. With a third-party company that did accounts receivable for various medical groups. So I started doing that, always was good at math, analytical type stuff, so quickly got really interested in the medical billing portion, looking at those EOBs, understanding how the contract rates are applied, how the write-offs are happening, who's responsible for what, understanding those deductibles and co-insurance. So I did that for a little while, and I really liked it, but it was a temporary position, so it was just a contract for a couple of months. Whenever I was let go from that, they didn't ask for us to come in permanently. So I was like, well, I really like that. Maybe I'll go back to school.
Yeah.
Right? So I got a part-time job at a hospital, part-time with benefits, because that was, very important. I was a grown-up, right?
Right at 20, you're like, oh, I have to come off my parents' insurance.
Exactly. And we didn't get to be there till 26 back then.
Yes.
Yeah. So I had to make sure I had benefits. And then I got pregnant with my daughter. So that kind of changed my trajectory a little bit. I didn't continue going back to school at that time. But I really enjoyed that medical billing and coding. So I thought, I hope I can find something similar. Found something similar, but not quite the same. I was working for a company that actually did Medicare Advantage billing, working with CMS. So they actually were billing the beneficiaries for their monthly premiums for the Medicare Advantage plans that were subsidized by CMS. So think you have Medicaid, you're eligible for that, but you also have Medicare. Now you're in a dual plan. So we were billing or processing subsidies for these Medicare recipients. I wasn't really a fan of that job. It wasn't what I thought it was when I heard it was a billing job. But I did stay there for a year, worked with quite a few people that I had worked with in that temp space. So we were kind of, all together there. But after that, I got a job. I lived in Northeast Pennsylvania. So now I live in Southeast Pennsylvania. And I was working at a private practice group there. I started in accounts receivable, and it was back to the same. I loved it. I learned it. It was great. We did not have a coding department. We only had an accounts receivable department. So as our group got bigger and we gained more specialties, particularly electrophysiology, we started getting lots of denials that no one really understood. Doctors coded for themselves. Again, no coding department whatsoever. So we had complicated surgeries going on and doctors just giving us codes, and we'd wait till the denials came because we didn't know what was happening. They were just going out into the ether and then coming back denied.
Which was very telling of the time.
Yes.
That's just how things ran back in private practice days. The understanding of the coding knowledge 15 plus years ago was not what it was today.
Yeah. Little to nothing is what I would say. Yeah. We were lucky that we knew a CAT scan was a 7,000 code, but I kind of started learning the coding because I'd have to pull the records to submit to insurance companies, and we'd get the denials and I'd read the record and I'd look at the description of the code and I'd think, wait a minute, this doesn't sound right. Maybe there's something better. So I kind of started figuring out coding on my own. They finally hired one coder to be our compliance department, and she was wonderful. And I told her how I was interested in learning how to code. And she taught me how to code E&Ms because that was the majority of what our private practice did. So the first thing I even learned coding-wise was E&M. Yeah.
And you still stuck with it after that?
Well, I did. Yep, yeah. I sure did. It was very interesting to me. It actually felt like a whole different side of what I'd been looking at, because I was thinking these complicated surgeries that are always getting denied, not how do I know what level of visit is. So that was really good. And then I kind of approached our management team and said, really interested in coding. I'd really like to do a job coding. Is there any way that is going to expand? We literally have one person.
Right.
So they kind of gave me a deal, right? Like, well, you can start coding. And if you start coding and you get a certification, give you a raise and we'll let you work in the coding department.
Oh, well, that sounds good.
It was actually really good. I had a very supportive boss at the time. And that's exactly what I did. I started training with the coder that was there. She taught me how to do E&M. I remember printing out a CPC practice test and doing it by hand. So I did that, and I took the CPC test and passed it on my first try and got my raise and officially became a coder. Luckily, I had already been working there for more than a year, so I got my A removed immediately, which was really cool. So I worked there for a while, and then when I left there, it's because I moved. So I moved about an hour and a half away, made the commute for about 2 months, which was terrible. If you know anything about Pennsylvania and our weather, it was dead of winter that I made that commute from southeast to northeast PA.
And it doesn't take much for it to make an hour commute like a 2-hour commute in the winter.
No.
Like a little bit of snowfall and all of a sudden it's double the time.
And mine was a complete turnpike commute. So if anything shut down on the turnpike, I was stuck.
Yeah.
But I did that for about 2 months before I got a job with a very large local health system as a physician auditor. Then when I say very large local health system, it's huge, huge, huge now. It was still huge then, but we had one auditor. Which was one auditor for an entire physician practice, which probably at the time had 500 plus physicians, and I don't know how many advanced practitioners. Probably triple that at this point, but still.
One auditor. I totally feel you. I think my last auditing role, working for a large organization, we had probably a couple thousand physicians and 4 auditors. So
I mean, that's a similar ratio. Yep. So I did that. But when I started there, I reported to a manager who reported to our director. And I quickly kind of gained, sight of the director. She saw what I was doing and how I was doing it. Got to know her a little bit more. She was ready to retire. So she decided she wanted to retire. And they said, please don't retire. What we really need from you is somebody to help work on our EHR. And we'd really love them to be certified in coding because we need to make templates for doctors. We need to especially make templates for specialty doctors because we've got an EHR and we've got out-the-box templates.
Right.
1, they're not really what they need for what they do in practice. And 2, how do we know they're compliant?
Right.
So she plucked me and about 4 other people from the coding department and made us into the EHR build team.
Okay. Was this kind of like Obama era where everyone was kind of pushing like it's now time and we have to get
definitely Obama area. Yeah. I mean, we were already on an EHR, but it was very much out of the box, and everything we did with that EHR, we called the vendor and we had consultants come in and do.
Okay.
So we didn't have anyone on site that was actually actively working on that EHR build type stuff. And we did more than just templates. We did a lot of things that have expanded my knowledge and got me where I am today. In an EHR, people have to place orders. They have to receive results. And that's when the quality payment program was first starting with Medicare. It was PQRS then, the Physician Quality Reporting System. And I became the owner of that, partially because a lot of our data came from the EHR, but also because I was building the EHR. So I could look at quality specifications and make sure all of our orderables and resultables that matched anything quality measure related had the correct coding, not necessarily CPT or ICD coding, but the correct coding on the back end so that it would become structured data and be able to be reported for the quality payment program.
Right.
So while I was in that EHR team, that became my job, part of my job. And 3 months of every year is when we would report for PQRS.
Okay.
So I had an entire team of people helping me, taking away from their side job, abstracting data from charts, pulling things that came in free text that weren't structured data, a 3-month project every year.
Right.
So we kept doing that, getting a bit more involved in quality, starting contracting with our local payers and enrolling in, quality programs that weren't quite the same as Medicare, but were kind of that little bit, the kind of like the glide path to where Medicare was. So same kind of measures, but not exactly getting to shared savings, just kind of incentivizing. We started doing things differently at the physician group. We decided, well, if we're doing all this and getting all this money from CMS, we need to incentivize our providers to kind of change the way they practice.
Right.
So in doing that, they actually created a brand new team, the Value-Based Care team. And I became the Value-Based project supervisor because I was already supervising the one very large project that we had that was value-based. So I did that. I loved that job. When I was doing that job, I not only worked with the physician groups and their staff on how to meet these quality measures, I helped create dashboards in the EHR so that at point of care, when a physician is seeing a patient, it will pop up and say, Victoria needs her colonoscopy. Victoria hasn't had a depression screening. Victoria's diabetic and needs her A1C checked. So that right at the point of care, they could see what quality metrics this patient matches and what they might be due for, so that they could be a bit more proactive in getting these things done for these patients. So a lot of my work was working with the staff, teaching them how to utilize these dashboards. But also I had a team that worked at the business office and continued to do that abstraction and work with those insurance companies to submit that data and also coordinate with the physician practices and, get policies and procedures going. Everything was brand new. So that was a really wonderful job for me. I loved it. I was very happy. But out of the blue, my colleague from back at that physician group in Northeast Pennsylvania called me and said, hey, I'm working at Optum, and there's a job that we have opening, and I think you'd be great for it. And I said, nope, I love the job I have now. I'm a value-based project supervisor, and it's wonderful, and I love it. And she said, give it a chance. I thought about it, and I said, well, tell me more about the job. And the job was working for Optum 360 on their natural language processing innovation team on their computer-assisted coding product.
Okay.
And I said, tell me more. So a long story short, I spoke with her boss. We got on great. Obviously, it's a very kind of niche field. When you can talk the talk with somebody, you get really
Right. Yes.
So I was talking about all my value-based work and all of that, and it turned out that they wanted to start doing some proof of concept work. They've had a computer-assisted coding product with Optum years and years and years. It's still, being developed day to day, consistently refining, but it's that product. It's going to code your record, and that's what it's going to do. We started doing proof of concept work, and based on my background with value-based, I did a lot of that. It was at the time, we had all kinds of names for it. Now it's clinical language intelligence, and it's a true product from Optum. But what we did is took unstructured data, and like I was kind of saying I was doing with the other EHRs, we had the natural language processing engine from the computer-assisted coding module read all of that text. And then instead of applying an ICD or a PCS or a CPT code, it would pull out SNOMED codes, blank codes, and RX norm codes, so that we would be able to see how those match in specifications, but more so clinical indications. So for an example, the big project I worked on that is now called Optum Case Advisor, but in POC, it was from a large executive health resources group actually in Pennsylvania that Optum had acquired. I think their main business was overturning appeals for inpatient claims that were denied and said, no, they should have been observation. So they're fighting them and saying, no, they really should have been inpatient, and here's why.
Right.
They literally had a binder this large of all the appeals they had ever won. So if they said, oh, I've got a patient that was in for a GI bleed and it denied, they'll turn to GI bleed and they'll find whatever appeal they won and how they won it and what, levels of whatever was there, what clinical indicators they found.
Right.
That made that in the chart.
Right.
And then they would pour through manually a chart trying to find the same clinical indicators so that they could win their appeal, basing it on a former appeal. That's the gist of it. Well, we turned that electronic for them. We took that giant appeal binder that they had. We OCR'd them, so we scanned all of them and turned them into text that would be searchable. Search that text, apply all those codes, and now you have structured data where instead of looking for certain blood pressures, certain lab levels, certain test results, pulling all of those out, telling you what they are, and applying structured coding to them should you need that for anything.
Wow.
Really enhanced their workflow. But it became a new product as well that they could now offer to anybody who wants it for the same reason. And obviously continuous refinement, right? The more appeals you get or the feedback you get from a client that's saying, hey, we got this is a new indicator that we know, we can find it. Or just add all the indicators and then you'll know. Low lab, high lab, pick out what you need. So that was really cool. And I really, really enjoyed that job. But I did that for about 2 years, and I'm the type of person, I tend to work at the same place, but I move around. I get bored.
Or someone finds out how talented you are.
Well, I'm not going to say that, but I will touch on that as well, because as you can see, you'll hear I have maintained relationships with all of these people. And like my friend that called me, like most of my career has been through my networking and the relationships I've built. But when I left there, I thought, what do I want to do now? Like, Optum, United Health Group, huge multinational company.
Mhm.
I could go anywhere I want. What do I want to do?
Right.
So I just started poking around to see, and a job came up for concept research and development. And what that team was is we developed, well, we ideated, it was called, so I thought of it. I got paid to think. We ideated and we developed concepts to save money for the insurance company. So essentially, find a medical cost savings, but utilizing my medical coding and billing knowledge. So I know the coding rule for this. I know oftentimes it's miscoded as this.
Mhm.
Well, now I'm going to look at some data of all the times of that miscode and see if I can find some patterns that might just look a little wrong.
Okay.
Or a diagnosis code that maybe doesn't match altogether. If we have coding for bill this code sometimes for non-occlusive disease or for occlusive disease, and that diagnosis code is for a non-occlusive disease on the occlusive code, I have reason to think either you've billed the wrong diagnosis code or you've billed the wrong CPT code. Something's wrong. So that was what a lot of my stuff was, finding claims where something was wrong and we should request the medical record to determine what the correct coding was.
So this was on the insurance end of things.
Yes, yes. So I was working for Optum, but the client was United Healthcare. So we were looking at United Healthcare claims. That job encompassed a lot.
Mhm.
It's obviously not just medical coding, medical billing. When I tell you I had to talk to everyone and their mother at United Health Group to get the concept approved, I'm not lying. That is where I learned to adjust to my audience. I'm so used to talking to other people who are medical coders, who are doctors. Now I'm talking to lawyers. I'm talking to people from network who are writing contracts. I'm talking to people who don't even know what a CPT code is sometimes.
Right.
But I'm having to translate my maybe complex concept, even complex to us,
Right.
into layman's terms so that I can get it approved by people within the company who don't know what I'm saying if I say the complicated words or if I start talking CPTs. So I really learned my presentation skills and also being able to adjust to my audience, which was infinitely helpful as I kind of progress. I worked very closely with medical directors there. One is, if he's watching, hi, Dr. Falk, because I'm going to tell him. But I lean on him a lot. He was my clinical guy at Optum. So non-clinical person, I like to think I know what I'm talking about, but I oftentimes don't. But I know the coding portion, and I can understand the rules and regulations. So with me or someone like me and a medical director by my side, presenting these concepts to people, it's always, it's weird to kind of go from the physician side where I kind of feel like I'm sort of the bad guy because I'm trying to tell you, like, here's what I need you to do and here's how I need you to do it, to you're on my team and we're fighting for the same thing. So that was a great relationship that I formed immediately and carried me through almost 4 years in that position. I worked very closely with lots of people. My team there was wonderful. I mean, I can't say enough about them. Most of them are still there. But again, about 4 years on, I thought, what am I ready for now? And I thought, maybe I'll get back to value-based care and see what's going on over there. I'm a couple years out. Victoria and I were talking before, you get a couple years out of something and you feel like you know nothing about it anymore.
Right.
So I applied for and got a job as an associate director of national value-based care operations, which I'm not an operations person, had never done operations before. So kind of in that journey of just being in health information management, I'm trying to kind of tick off those boxes. What skill do I not have yet?
Right.
And operations is one that I didn't have.
So in operations in that role, were you just overseeing general operations or did you have a team under you as well?
So they weren't directly reporting to us, but we were responsible for the value-based care team. And it was for United Healthcare. So that particular team at United Healthcare was probably 500 plus clinical transformation consultants. Mostly nurses, some coders, some people that had just been in the field or in health information management and made their way to this, maybe whatever trajectory they got there. No specific, you have to be this or you have to be that. But they worked directly with practices who had contracted with United Healthcare and value-based care arrangements to help them meet their value-based care metrics.
Oh, okay.
Trying to achieve their goal of achieving their shared savings or whatever incentives, whatever they're contracted for. But at the same time, obviously, saving that same money for United Healthcare or achieving shared savings for them. So it was a mutual partnership going for the same goal, but on both sides. But we were responsible for that operation. So the operation part I was responsible for was twofold. Strategic operations. So we've got all these value-based care initiatives, but what else can we do? We have certain ways that United Healthcare would contract with practices in a value-based care arrangement. But what else can we do? We have lots of fee-for-service. How can we maybe convert some of this fee-for-service revenue to value-based revenue?
Right.
So it was strategizing on that. So again, looking at lots of data, looking at claims, looking at diagnoses, finding those patterns. Could this be a bundled payment situation? Is this a surgical procedure? What can we maybe do with pregnancy and maternity? It's already paid as a bundle, but what else could we do to kind of make that an episode of care instead of just claim by claim by claim type things? So that was one part of it. And then the other part was the true operations part, which was defining ratios for these clinical transformation consultants. Because you could have 5 practices and I could have 5 practices, but 3 of my practices might have been on EHR for years and years and years and have their own quality department, and they don't even really need our help. And we might have 2 practices that are brand new and don't know what's going on and don't even understand how to submit anything for quality. So I had to figure out workloads and ratios and how can we assign these practices certain levels, and what does that actually mean? What is a level 1? What is a level 2? What characteristics do they need to have? What are the exceptions to those characteristics? To make sure that no one was being overworked, no one was being underworked, but that every practice was receiving exactly what they needed.
Right.
Which was honestly totally new thing for me. I had never done anything like that. So very big learning experience, very big learning curve, but still kind of under the umbrella, because as I move up in health information management and more leadership roles, those are kind of things you have to deal with. So that was really good for me.
If you don't mind me interjecting right here. So one of the things I wanted to talk to you about was the value-based care. And you mentioned about how kind of moving away from the fee-for-service and the value-based care and how we can enhance that a little bit more. I feel like we've been hearing so much for how many years now? Oh yeah, value-based care. This is the future. We're going to no more fee-for-service. We're not going to have this fee-for-service. It's going to be gone. And it's been so long that I've been hearing this now. And I'm just like, okay, when in the future? Because it's been how many years now? And we're still so concentrated on fee-for-service. And the value-based care, I don't feel like is progressing the way everyone's been saying it's going to.
It's a slow walk.
Right.
What you'll notice is year by year, fee-for-service reimbursement is going down. Value-based reimbursement is going up. But like you said, that's been going on for at least the last decade, if not longer.
Yeah.
Last 5 years or so, more and more prominent as you see more and more value-based arrangements come in. But fee-for-service is still the predominant revenue. I don't think in my lifetime we're going to see value-based care take over. I mean, we're always going to have acute illnesses and acute injuries, right? Things that you can't be helped. I got the flu last week. I don't want my doctor to not get paid for taking care of me because they couldn't prevent me getting the flu. I fell down the stairs and broke my ankle. Same thing. I mean, there's some sort of bundles you can do with surgical and post-care, but what about me who didn't need surgery?
Right.
So you're always going to have acute illnesses that you can still give quality fee-for-service care for and that you need to give quality fee-for-service care for. I just don't see how. I mean, I'm not going to say it can't happen, but I've seen a lot of data and I've seen a lot of claims. And to make a value-based care arrangement that works all the time for everyone isn't going to work. Even in bundle payment episodes, you see things like that because things happen that are unrelated and people need $1,000, $10,000 injection, or a patient has cancer and after their knee replacement, and that still gets bundled in their bundle payment.
Right. And even I think to some degree, the AMA has a very strong hold on their CPT code set. And it's been even interesting. There's a lady, Sherry Poe Bernard, who recently was asked if she was going to be making the 3rd edition of her risk adjustment coding book, which was published by the AMA. And the AMA had said, oh, well, we're not really interested in continuing producing this risk adjustment book because they get paid for CPT. So I thought it was very telling that they're not really wanting to push the value-based care, the risk adjustment coding care models as much as they want to push their fee-for-service, which they have the licensing fees for CPT.
Which makes sense from a business view, right?
Right. It's like, I get it, but...
Yeah. The one thing I always forget to mention that is I did finally go back to school while I worked through United Health Group. So
oh, wow.
When I was in the NLP team, I started going back to school for my bachelor's in health information management. I attended Western Governors University, which is completely online, and it's an at-your-own-pace university.
Oh, wow.
And having been in the field for about 15 years, I got a bachelor's degree in 8 months.
Okay. You have your master's, though, now, don't you?
I do. So after I got my bachelor's degree in 8 months, I thought, maybe I should try for that master's. And the good thing is, tuition reimbursement through work is what I used for that. And the university that I went to, being a kind of at your own pace, competency-based university, I was able to kind of have my employer pay for almost all of my schooling because I finished it so quickly.
Oh, wow.
So it was great. Hi, no student loans. I would have never had that had I went back to school when I was 20, right?
Right, exactly.
So, sometimes you don't get there right away, but then you get there. But yeah, I went back again to WGU for my master's in health leadership. Has since become a master's in health administration, which everyone obviously knows what that is. I'm trying to get my diploma reissued just via MHA so that no one asks me what an MHL is anymore. But for now, it's a master's in health leadership. But that's also been something that helped me almost kind of check that box for those other associate director jobs, because while I had been in the coding field and the health information management field for that long, I didn't have that associate's or bachelor's degree checkbox sometimes, right? I had all the certifications, but not those checkboxes. So as soon as I was able to check the box, it was easy for me to make those transitions. So that was really good too. And again, I was able to get my employer to pay for those things. So I will always say, take advantage of those tuition reimbursement programs if you want to, because it will definitely help you in your career.
Yeah. So last you were saying that you were working in the value-based care with UHC. So then what happened after that?
I was laid off from UHG. So there was a bit of a mass layoff at UHG back in August of this year. And I was part of that layoff. So we were a brand new department, and then they were looking to cut costs, and, pretty easy to get the brand new people out of there.
Right.
So we got laid off, and I went on vacation the week after and thought, okay, what am I going to do? We were already scheduled to go on vacation. So I said, I'm not going to do anything. I'll go on vacation. When I get back, I'll start doing things. So I updated my resume, and I started looking around at what sites to upload it on, what jobs to apply for, and kind of just got started. And I immediately got a call, but it wasn't from a job that I applied for. It was from a job that had found my resume on one of the sites I had uploaded it to.
Okay.
Happened to actually be a local company who reached out to me and asked me if I would be willing to interview for a position. So I did some pre-negotiating before I agreed to do the interview. And then I interviewed, and I got the job within a week. I went in and met everyone on my 40th birthday. Made sure to tell everyone that I came in on my birthday, just in case they didn't hire me. I wanted them to feel a little
bad about it. Make it could have been doing something else,
but I was
here instead.
But I do have a funny thing about that too. So on my birthday, I met everyone, and then about 3 days later, they called and offered me the position. So I've just recently started as of October 16th as the coding compliance manager at medical imaging of the Lehigh Valley.
I know. And now you've gone from working remotely, right?
Yes.
To working in person. How's that been going for you?
Interesting. It's going to be hybrid. It is hybrid. I am actually lucky enough that I'm replacing someone that's retiring, and she will be there through the end of the year. So I'm in person with her for the next 2 months or so, hoping to download her brain into mine. And then I will be hybrid from then. I already worked from home in my 2.5 weeks. So it'll probably be, not so much in the office, but it is a big change. I haven't commuted in almost 7 years. Again, beyond lucky that this is only 10 minutes from where I live. So I can't complain. I don't even have to get on the highway. And I said, if I had to take another job in an office, I couldn't have asked for a better commute, honestly.
Right.
So pretty happy about that.
I'm a little surprised that you, or maybe you have been, and we just haven't discussed it, been tapped by a lot of these AI companies, because a lot of your skill sets seem to be something that I feel would be of interest to a lot of these companies developing the AI coding modules and programs.
I have been approached. A lot of them want a 1099 employee. And I don't want to be a 1099 employee. I have a family that I'm supporting. Benefits, as we've said before, are very important.
Right.
So I've kind of wished away at all the 1099 type stuff. But I have had some people reach out to me through LinkedIn, especially. Actually, recently as last week, I've had someone reach out to me for a part-time 1099 position, developing AI logic for claims for CMS. Yeah. So it is something. And again, LinkedIn, make sure that you're putting yourself out there, because even if you're working full-time, some of that stuff I'm thinking, like, now that I'm back in physician side, like, maybe I do want to know what claims AI logic is being developed.
It's like the gold rush right now, because like everyone's trying to quick get in there and develop like the ultimate program that's going to interface with Epic and and everything. And it's fascinating to see them all kind of like rush together and try and get
Everyone's converging upon it.
Yes. People were telling me 6 months ago, they're like, your job's going to be gone in 2 months. And I'm like,
Never.
I don't know. The fax machines that we're still using, I don't know. I mean, I'm not saying there's going to be some changes. There's definitely going to be.
I don't think it's ever going to take over for coders or health information management professionals. And now that I'm on the physician side and I'm seeing the AI advancements on the physician side, which is totally blowing my mind. It's a whole different AI world that I'm used to. And I love it. I think it's amazing because, again, like you said, I'm very passionate about the patient care aspect. I don't think I could be a doctor or a nurse. I can help the people who help people is how I kind of put it, which is what I feel like I've been doing for the last 20 years in one way or another.
Yeah.
But yeah, that's my career.
So you have a lot of different certifications in addition to your ones that you have for your degrees from Western Governors University. Yep. Yeah. So you have your CPMA, your certified auditor, your accredited healthcare fraud investigator, which is very interesting. So which one of your certifications has been the most challenging one?
Well, I'm going to go twofold, right? So I have an RHIA, which is Registered Health Information Administrator through AHIMA. That one is hard to attain because you need a bachelor's in health information management.
Yes. Yeah. It has to be through the right program.
Through an accredited university. Exactly. So that in itself, I couldn't just say like, I know all of this. Let me go take the test as I could for, a lot of the AAPC certifications where I'd just been in the field and had been reading medical records. And I thought, I am pretty much your auditor. Let me see about this test kind of thing, So that in itself was kind of a big goal of mine to get my RHIA, but I had a big hump to get over in order to get that done. And then the one that you just mentioned, Accredited Healthcare Fraud Investigator. So that's through the National Healthcare Anti-Fraud Association, the NHCAA. That one was very hard to get because unlike a lot of the certifications that we would hold in this industry, you need continuing education units before you can even apply.
Oh, wow.
And so many of them have to be direct from NHCAA.
Oh, okay.
Yes. So it took me about 2.5 years to get the relevant CEUs to even sit for that test because they also have to be directly towards fraud. Now, I've never worked directly in a fraud department. I didn't work in an SIU, Special Investigation Unit, which is really people who have that certification often work in an SIU. Mm-hmm. But when I was doing concept research and development, we found a lot of fraud.
Yeah.
And that was very interesting to me when I started finding the fraud. And when I was doing all that data analysis, I wanted to learn, how do I actually analyze this data and determine patterns that might indicate fraudulent activity? Mm-hmm. And that's a big part of that AHFI certification. AFI is kind of what we would call it.
So was that expensive then to have to get all of those CEUs? Like, how do they break that down? Do they make you pay for each CEU and then pay for the certification exam and membership and all that?
Yes, is the short answer. Okay. But in my case, I was lucky enough that at the time I was employed by UHG, who has a corporate membership with the NHCAA and offers monthly webinars that NHCAA offers. So I was able to get their direct CEUs in that way without having to purchase them myself. And then the other CEUs could have either been direct from NHCAA or at least pertinent to the fraud investigation. So when I took Excel classes or SAS classes or anything data related, I could kind of use that towards it. But not when I took like cardiology coding.
Yeah, right. Yeah, so like the AAPC and the AHIMA ones will kind of cross over because AAPC will take AHIMA CEUs.
For the most part.
Vice versa, right?
Yeah, but not necessarily those. Yeah, so it was pretty hard to accumulate them time-wise, but I was very lucky that the employer that I worked for at the time provided for that. I also had professional development opportunity here at Optum and UHG. So I was able to say at the beginning of the year, here's what I would like to accomplish for my professional development this year. And if it was approved, Optum paid for that or UHG paid for that. So 1 year getting that certification was my professional development goal. Therefore, I got them to pay for it. So I kind of did. I got my CPMA, my CPMA, CRC, and AFI that way.
Oh, wow. It's always nice when they're clear with you about, hey, we have a budget for you.
And ask, honestly, ask the question because sometimes they've never even thought about it.
Right. And yeah, because I've been in situations where I was managing a team and they're like, oh, I want to go to this conference. And I'm like, okay, well, our budget this year can't afford it.
Right.
But when we're scheduling the budget for next year, remind me because we can put that in for next year to have that additional information.
Yeah.
We can't guarantee that we'll get it, but we can put in the request to get an additional budget for continuing ed or for a conference you need, because maybe we're bringing on a practice that has a certain specialty and we don't know anyone that has the training in that specialty, so we have to send you to a conference.
Yes, and I asked the question because with the job that I have now, I would be managing people, and I haven't managed people directly actually ever in my career. I've managed without the authority of them directly reporting to me,
Right.
but I've never had people who are my direct reports. So again, kind of each thing I do, I'm kind of gaining one thing, even if I'm going back to something I've done before. And that was one of the questions I asked in my initial interview was, what's my education budget? What's my education budget for my employees?
Yeah.
What type of training do they already have? What type of certifications do they already have? What are you willing to support for them to get?
Yeah.
Because again, if we're talking about my career, all of the leaders in my life have helped me move on to the next thing.
Right.
And I want to be the same type of leader that I've had in my life, because I want these people to be able to do whatever they want to do.
Right. And you want to be the right leader for them.
Yes.
And if you don't have the situations by the rest supporting you that they're saying, hey, we are also invested in their continuing education,
Absolutely.
then you don't get to be the good leader.
Absolutely.
And it's so frustrating when you're like, yes, I know this is important, and if it was up to me, I would absolutely give it to you, but I can't.
Yes. And I honestly feel genuinely very excited about my new position, because they seem to be very, very willing to let me do what I think needs to be done. And I really just want to grow my team, and if whatever they need to do for professional development at work and outside of work, I want to be able to give them that opportunity. And I really think that based on the chats that I had before and while being employed at my new job, I think I'm going to be able to do that. And again, I want to follow in the footsteps of these great leaders who have gotten me where I am.
That's so amazing. So we have a lot of people on my channel that are like newbie coders, and they ask me a lot about getting into health information management. Should I get my RHIT? Should I get my RHIA? Based off of the broad knowledge you've had of the health information landscape, what advice would you give to someone who's just wanting to get into health information management?
I would say put yourself out there. It's a vast, vast industry. It's not just medical coding. It's not just medical billing. It's not just EHR. If you think about a hospital, how many people have to work at a hospital and how many people have to do something to make one procedure go through?
Right.
What actually interests you in health information management? Are you an analytical person like I am, and you want to look at this math and figure out this billing and coding rules and all of that stuff? Because that's what really tied me in is learning, I've always been analytical, but now actually learning how to analyze. And then from there, kind of that data aspect as well. So you could do all kinds of things. You could be a production coder, you could be an auditor, but you can also be a data analyst. You can be a system administrator, and you're still health information management. Like, health information management is such a huge thing. So just think about where you want to be, and then that probably fits in somewhere in health information management.
Have you in your experience done any kind of more programming end of coding, like SQL and stuff like that, or Visual Basic, C++, all that?
C++.
I don't know.
I got C++ when I was 15 years old. No, I have done a little bit with SAS. So when I was at Optum and doing the concept research, we would look at huge, huge data sets. We did have data analysts, but a lot of times I wanted to run, if I have a little idea, I didn't want to ask a data analyst to run the data. I wanted to test my hypothesis before I started getting years and years worth of data. So I did learn some basic SAS so that I could run my own queries when I had a random thought or hypothesis, or so that I could whittle my hypothesis down.
Okay.
So that I'm not being so broad, and I can kind of see, now I see what this looks like. Let me apply some more criteria to this, because I'm a little too broad. I'm picking up a little too much of this universe. So a little bit self-taught on that, but got the opportunity to learn. I was given the opportunity, given the programming license, given the access through, again, my employer. And again, I can't say enough, ask the questions. You can probably get more than you realize by explaining why you think you need something, because, again, such a big, vast industry,
right,
and so many things going on and so many different ways to get to your information.
I want to dial it back here for a second, because I just remembered you said something about AI on the physician side. So what have you seen so far with AI?
So I'm working with a group of diagnostic and interventional radiologists, and I've seen two forms of AI that's being used in practice right now, which are both amazing to me. One is, I believe it's called AI Doc, and it's for actual images on radiology. And what it does is it produces a heat map of the image. So kind of think if you're looking at the computer and you like do a reversal of your colors, it produces a heat map of the image that points out an anomaly in the image. Now, it's going to guess and it's going to try to know this is a pulmonary embolism or this is whatever, but it's always an anomaly. And I spoke with a physician who showed this to me live and actually showed me a pulmonary embolism. So he pushed it. It did the heat map, and you could see a very large anomaly space. Now, it was a very large PE. He would not have missed it, clearly, but he was saying, but it will also catch ones that are very small that I honestly might have missed.
Right.
And if I can get this AI, like it's not always right and I have to correct it, but if it can find one thing that I would have missed myself, it's more than paid for itself. And I 100% agree. It was amazing to see that. And he showed me a few where it was right about what it found and a few where it was wrong about what it found. But also there's machine learning algorithms on the back, and you provide feedback whenever you change it. So from working on the other side, developing these types of things, I know that feedback's going back to whoever's producing that, and they're going to use that to refine that product and make it so that it's working better and identifying more properly.
Yeah, and I think it definitely makes the work that we're doing in healthcare so much more meaningful because we're able to concentrate on the more detailed information instead of being constantly overwhelmed. Now, of course, that doesn't come without some risks. Of course, we have a lot of issues that we're seeing right now with, and kind of new versions, I guess, of some issues we've already seen. Providers using the same macro or copy paste. And now it's just, okay, well, now we're automatically having some sort of AI tech fill in a note, but it's not necessarily correct or they all look the same. So it's the similar risk, but I think there's ways that we'll be able to utilize this more tactfully in the future so that we can produce things that are more concentrated on what we need to focus on in healthcare.
Yes, I agree. The second thing that I've seen has to do with their dictation of their reports and also with quality metrics, which this is part of the reason I'm very excited about it because the radiology side I'm learning doesn't have that many quality metrics that they can really utilize in their practice because diagnostic radiologists are just reading diagnostic tests. Interventional radiologists are performing complex interventional procedures.
Right.
So both of those scales kind of don't really fit on what we talked about before, the existing quality paths. But there are some, and most of them are around incidental findings in radiology. So if I go for a scan, my abdomen and pelvis, but the field of view shows my lungs and there's a nodule on my lung, then they would find an incidental nodule. They weren't looking for anything in my lungs. So we have a program that we are testing right now with some of our docs, and I watched it in action. It takes their dictation. They're still dictating the entire body of that report themselves, but it takes their whole dictation and it formulates the impression from the findings that they have in the body of their note. And it does it in their own voice. So they teach it. As they start it, they just dictate everything, including the impression for however many studies. And then it's saying it in their voice, however they tend to phrase things, whatever they say. And of course, they can make those edits. But it's also alerting them that, hey, that incidental nodule you saw fits this Fleischner criteria. And if you place that Fleischner criteria in there, that's a quality measure that you identified that. So it can automatically know, based on the fact that you dictated a certain size nodule that you saw, that then meets the criteria for an incidental finding for the Fleischner criteria, and it'll put in your criteria automatically so you're not trying to, figure out the right way to say you used the Fleischner criteria for that incidental finding. Which is really cool from my perspective because now my doctors don't have to work so hard. They're already, same thing, we've seen it for years. I identified the nodule. You did, but I needed to know about the Fleischner criteria, and I needed to know about this and that. So it kind of prompts them and allows them to either choose that they want to use that criteria or, no, there's an exception. This patient's actually younger than 35 years old. I wouldn't apply that criteria. Well, then they can say younger than 35, and it'll give them the criteria for that. So kind of like a decision support tool, but it's actually generating that from their findings, which was very cool to see.
And very powerful in the right hands because it's just so much great help to those physicians that know how to use it appropriately. But then, of course, we have those outliers. But for the intent that it should be utilized, just amazing. That sounds fantastic.
And honestly, the productivity benefit for those physicians, right? They're dictating their studies. They're not having to type out or dictate all this special criteria that they know in their brain and that they are using, but that they have to verbalize or state in the exact right way for it to count for them. which I think is immensely helpful because, we've seen it for years with patients over paperwork and things like that, right? So it's the same kind of idea on that sense, but anything to me that makes life better for a doctor that can enhance patient care is great.
Yeah, especially when we're seeing so much in physician shortages and physician burnout where, nowadays you get sick or you need to talk to your doctor. It's like, okay, well, you either can go to urgent care right now, or if you want to see your PCP, they can see you in 3 months. Or, you go for a problem and you're supposed to follow up and oops, that follow-up visit never got scheduled. Yeah. And then it's like, what are you doing here? We're like, why do you need to see your physician?
Yeah. And I can talk about that on a whole nother podcast. I'm going to invite my husband who comes from a place with universal health care.
Yeah. Yeah. It's a
common conversation in my house.
So, Alison, this has been great. I'm so excited that you came down to talk to me today about all these things with health information management, with AI. What is next for you?
What is next? Well, now that I am back working in my local community, I have applied to be the president of our AAPC chapter to follow in my friend Victoria's footsteps. And I'm pretty sure that I'm going to get it, considering I was the only nominee. But when the nominees came out, I also happen to know several of the other people who applied for positions that I used to work with at previous institutions. So I'm very happy to see who I think my team is going to be. So I think that's what's next for me is kind of getting myself more back into the local health information management community since I've kind of stepped away from that for the last 7 years, meeting the people in my community that are doing these types of jobs and really just embracing my new position, building the team that I have, growing them professionally, and being the best leader I can.
Yeah, well, I think the Allentown chapter is so lucky to have you.
Thank you.
And it's going to be great to see what you're going to be developing. Feel free to tap into me because I like you. And you came to talk to me today, so I can certainly present for the Allentown chapter if you need a speaker for the 2024 year.
Yeah,
but
sounds good.
Thank you so much again, Alison, for meeting with me and my viewers today.
Thank you.